Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Alexion Pharmaceuticals, Inc.
All right, good morning. Welcome to this program where we will be discussing advancing care in hematopoietic stem cell transplant thrombotic microangiopathy, or TA-TMA, strategies for early recognition and management. My name is Michelle Schultler. I am a physician at Emory Children's Healthcare of Atlanta, the AFLAC Blood and Cancer Program, and I am joined here today by two eminent scholars who I'll allow to introduce themselves.
Good morning, everybody. My name is Vincent Ho. I'm a professor of medicine at the Harvard Medical School and a clinical director for the adult stem cell transplant program at the Dana-Farber Cancer Institute in Boston, Massachusetts.
Hi, everyone. I'm Uday Popat. I'm a professor and deputy chair ad interim in the Department of Stem Cell Transplantation at the University of Texas, MD Anderson Cancer Center in Houston, Texas.
Great. Thank you, Dr. Ho and Dr. Papa. We are really looking forward to a great discussion today. So over the next 30 minutes or so, we want to discuss some key principles in the diagnosis and management of transplant-associated thrombotic microangiopathy. We hope that at the conclusion of the program, you have increased knowledge, feel more competent and confident in implementing best practices to identify and diagnose these patients early. So to get us started, Dr. Poppet, would you like to tell us a little bit about what is TA-TMA?
Thank you, Michelle. TA-TMA is really a disease of endothelium. Patients who are genetically predisposed to it or have endothelial injury do get conditioning treatment that we give as a part of stem cell transplantation, which damages the endothelium. The next step or next trigger is things like calcineurin inhibitors, which are toxic to the endothelium, or for that matter, sirolimus, or infections like some viruses which may affect endothelium. Alloreactivity or graft versus host disease is another predisposing factor. So many of these combine together and initiate an inflammatory cascade which activates the complement pathway. Now, further activation of the complement system further damages the endothelium and eventually activates the coagulation system, activating the tissue factor and leading to the small vessel or microvascular thrombosis and tissue ischemia and organ damage. So this really starts in the endothelium, and really endothelium is where the problem is, but it is uh, increased, the pathogenesis is enhanced by complement system, and so addressing or attacking or suppressing the complement system may be one of the ways to treat this, as we'll talk about further.
Yeah, thanks. I sort of think of TMA as a multiple hit process where some patients, particularly in the pediatric world, come in very heavily pretreated for perhaps their underlying malignancy, and then they get another hit with radiation or chemotherapy, and then another one with infection and graft versus host disease, and eventually sort of topple over. Dr. Ho, is that fair? Is that how you think about this disease?
No, absolutely. You're right on. I think there are certain populations that are particularly susceptible. There's genetic disposition, especially in minority populations. African Americans have a higher risk of this disease. So patients who have been heavily pretreated or of certain genetic backgrounds are at risk. And so after transplant, we need to be very, very cognizant to watch out for this condition because it mimics a lot of other conditions after transplant. So if you don't continue to think about the possibility of underlying TMA, you may not you may miss the diagnosis. And I think that's been one of the problems over the years, is that patients with graft versus host disease, they have BOD, they have other conditions that are coexisting, but there's an underlying TMA that's going on that might not be recognized.
So, Michelle, you see this disease a lot in pediatrics, and you have a lot of experience, a lot of research that has been done in pediatrics. Uh, a priori, when a patient comes to you, which patient, what factors would lead you to believe that this person is going to be at high risk?
Yeah, I think it's a great question. So, before they even begin the transplant process, as Dr. Ho has mentioned, we know that your racial and ethnicity background is a risk factor for developing this disease. We know that females, especially in adults, for female sex, seems to be a risk factor for developing this disease. And your transplant indication, so in again, more of this data is from children, but certain immune deficiency dysregulation syndromes like HLH, severe aplastic anemia patients who were refractory and have had years of calcineurin inhibitors, they seem to be at increased risk. We've shown that patients with sickle cell disease are at increased risk. And then this is really more applicable to children, but children with neuroblastoma seem to be at risk. And so those are known risk factors. And then what we do in the transplant procedures are also known risk factors. So the stronger chemotherapy and radiation seem to be risk factors. And then, as you've highlighted, I think very nicely, and we're going to talk about this a lot, is the risk factors for graft versus host disease. So HLA mismatch and anything that puts you at risk for increased GVHD and subsequent and viral infections also put you at risk for these diseases. So that's who I think about, at least in our pediatric cohort. Are there any other risk factors, particularly in adults, that I'm missing?
No, I think you pretty much covered it all. Vince, anything you can think of?
Yeah, I mean, I think the big thing that we've seen at the Dana Farber is that sirolimus as a drug, when combined with calcineurin inhibitors, really does compound the risk significantly. Uh, you know, we sort of stopped using sirolimus last few years, and our incidence of TMA has really declined. But previously, when we were doing myeloablative transplants with sirolimus, we were seeing about almost 10 to 20% patients, with some form of TMA.
Yeah, and I think one of the particular thing relevant to adults is approximately half of our transplant in many of the adult centers are reduced intensity transplants. So we do see a lot less incidents, mainly for that reason.
Yes, and I think sort of reducing the use of TBI has also helped.
Yeah, and in children, I think this might be more relevant, but certainly second transplants, third transplants, fourth, they do increase your risk of developing this disease as well. Um, and and Dr. Papa, you talked about how this is an endothelial problem, and many of the hematologic manifestations are shared by other TMAs. So anemia, thrombocytopenia, evidence of destruction of red cells. But in the transplant setting, I think somewhat more uniquely, lots of patients have end organ damage, and not just the kidneys or the brain, which is what's thought of as in more other TMAs. Do you want to tell us about some of the other organ manifestations that we see in TMA or that make you think about TMA?
Yeah, so I think what is very well known, or what is very well talked about a lot, is because of the name thrombotic microangiopathy, or TTP. We all think about anemia. We all talk about thrombocytopenia, but I think the more important manifestations, sometimes we miss out, are renal dysfunction, proteinuria, and acute kidney injury. I think the next organ is gut, particularly the involvement of the gut causing abdominal pain, sometimes nausea, sometimes diarrhea, and the bleeding from the gut because of gut involvement. Lungs are involved as well, and diffuse alveolar hemorrhage is known to occur, and some patients can get pulmonary hypertension. Serositis is another manifestation, pleural and pericardial effusion related to this. And finally, I think a neurological manifestation, and many of us have been used to thinking about PRES or posterior reversible encephalopathy, which simply put, is hypertensive emergency, if you will, hypertensive urgency, where it is malignant hypertension. So you have altered mental status, high blood pressure, and leading to seizures. And in the extreme scenario, can lead to cortical blindness. I've seen a case like that as well. So these are some of the manifestations. Anything you would like to add, Vince?
Yeah, no, I think that was a great summary. The way I think about it is really sort of thinking about TMA as a systemic disease, and it depends on which organ bed is more affected. You see manifestations in those organs. So, certainly the kidneys is by far probably the most common single organ that we think about, but it's important not to forget the other organs. Sort of especially recognizing that GI intestinal TMA is a real uh, entity. When I first started doing this, we didn't even know that it existed in the gut until the Japanese published their literature on patients who read autopsy uh, from having gut GVHD. It was found out intestinal TMA. So yes, nowadays I think any patient who has severe graft versus host disease, that we're always very cognizant for the possibility that they may have TMA either in their gut or in other organs as well.
Yeah, I think that's a great summary. Most of the literature, I think, reporting the percentage of how many patients with TMA end up having organ manifestations, I think most of it comes from pediatrics and suggests that about half of the patients that are identified as having TMA end up having organ dysfunction. We'll talk about some challenges in identifying them, and certainly that's been my experience too. In our pediatric center, about half of the patients with TMA seem to have this self-remitting, they're fine, they don't get into trouble, and about half really get into multi-organ dysfunction and failure. And it's interesting that the organ involvement does seem to be different by center and by study. So, like, as an example, at our institution, we have a lot of pulmonary involvement, lots of diffuse alveolar hemorrhage and pulmonary bleeding. So I'm interested, Dr. Ho and Dr. Poppet, in your practice, what percentage of patients do you think have this more severe manifestation?
Yeah, so in our practice, we are somewhat behind pediatricians and you guys in recognition and treatment of this disease. And so many a times when we diagnose these patients, they are fairly advanced, and which is to say that our incidence is not as high as reported in some of the pediatric study. And partly that is because we don't recognize it often enough, and we don't think about it often enough. And I think that's something that needs to change, and we need to do that. Vincent, any thoughts?
Yeah, no, absolutely. I think we're far behind the pediatricians in this field. We need to do more screening to so that we pick up these cases a little bit earlier. But in terms of just really sort of knowing how many percent of our patients have severe TMA, it's it's you can't really get that data from the literature because until recently, we don't even have a standardized definition for what constitutes as severe, right? So we're only looking at multi-organ dysfunction, yeah, and that number is going to be smaller. I recall a study that we did a number of years ago here where we reviewed 2,000 patients who undergone myeloablative transplant and tried to apply the City of Hope criteria to these patients retrospectively. And what we found was about 10% of our patients met the definition for definite TMA, which involves renal dysfunction. So at least if you go by that criteria, about 10% of our myeloablative transplant patients would sort of meet criteria for having renal dysfunction with TMA in that one analysis. But if you apply sort of the current criteria to these patients, I probably say, probably upwards of 20 to 30% of our patients will probably meet some of these criteria if you're looking for just, 4 of the 7 criteria. But if you're focused on like having renal dysfunction or having organ dysfunction, that number is probably more around 5 to 10% of the ablative transplants, and it's probably going to be less with the RICs.
But I think this is a great segue. So we sort of We've introduced what TMA is. We've introduced that there is a severe phenotype. How often it occurs is not entirely clear, but it does happen. And then I think we really get to the meat of this discussion, which is how do we identify these patients? And Dr. Ho and Dr. Poppet have been working on this for a long, long time. Can you sort of briefly tell us what is this, the history, kind of where we've been, the differences in some of the criteria that have been proposed, and some of the themes that are in common, and talk a little bit about biopsy and the role of biopsy in this disease.
Yeah, so I mean, if you go way back, this started as an offshoot of TTP, or thrombotic thrombocytopenic purpura. So we all saw these patients on our hematology in our hematology training, and talked about these. And when we started our transplant practice, we would see some patients who met the criteria that fit the standard TTP. So stem cell transplant became one of the uh, one of the treatments that was associated with TTP, and transplant associated TTP, or thrombotic microangiopathy term, came around. In early days, there was even a discussion whether this was a real entity or whether this was just GVHD. And I think there was a very nice autopsy study which showed that yes, TTP, or thrombotic microangiopathy, transplant related, does occur. And since then, the criteria started with criteria that we were using for diagnosis of TTP, which is microangiopathic hemolytic anemia. So patients have anemia. Now, the challenge here in transplant patient is many of our patients are anemic. So how do you define somebody is newly anemic? So obviously, if they have recovery of red cell count, and a recovery of white cell count, and red cell recovery has lagged behind, or somebody who had recovery of red cell count and now starts needing transfusion, you can think about it. I think one of the biggest factor that came along was presence of fragmented red cells, or cystocytes. So as classically trained hematologists, you'll go to take a slide and look at under microscope and see cystocytes. Now, those of us who have done this, you know that even in normal people, sometimes you see this. So then what level you use it? So some of the criteria, and I won't go into the details of each of the criteria, but some of them said, okay, you need to have 2%, more than 2% cutoff. But then you end up missing the milder cases. So that was first thing about microangiopathic hemolytic anemia. Now, LDH is also elevated in this disease, so that became another marker. Thrombocytopenia, again, as a transplant doctors, we see thrombocytopenia in all the patients. So how do we define who has thrombocytopenia that is caused by this disease? And really use the same analogy that I used for anemia, wherein your platelets have not recovered, or they recovered and now they again patients started needing platelet count, or they have dropped in platelets. I think renal dysfunction, again borrowing from HUS, it was the next criteria, and many of the studies involved it. And I think more the most recent criteria from Cincinnati, they incorporated this urine to protein creatinine ratio, which I think is very significant, and which most of the uh, uh, earlier studies or earlier definitions did not have. Some early definitions did include the neurological dysfunction, but most did not. So essentially, in early days, it was mainly clinical diagnosis. Obviously, we never do biopsies in our transplant patient, or I should say, we rarely do biopsies because obviously because of risk of bleeding and thrombocytopenia and coagulopathy. So diagnosis essentially is clinical, and they have entailed at least microangiopathic hemolytic anemia, cystocytes, elevated LDH, thrombocytopenia, uh, and renal dysfunction or acute kidney injury. I'll
I should like to add one thing. That was excellent, Uday. Real nice summary of where we've been the last 20 years. But I just wanted to mention, sort of 20 years ago when I started doing this was, sort of there was no such term as TMA. We coined the term TMA, transplant-associated TMA, through the CTN network because we were tasked with coming up with a definition for this disease for reporting. So the original CTN criteria for TA-TMA was actually created as a clinical trial SAE reporting. And so because we wanted to capture the significant cases, that the original TMA criteria included organ dysfunction, like renal dysfunction or neurologic dysfunction. And so I think one of the biggest criticisms of the CTN criteria was that it was missing all the earlier cases or the milder cases, and only capturing the cases with renal and neurologic dysfunction. And so that's where Cho came in later and revised the criteria to not require organ dysfunction to capture overall TMA. And I think, obviously more recently with the Jodel and the pediatric criteria, adding the biomarker, the C5b9, and adding that you don't need to have actual frank renal dysfunction, but just elevated protein itself is an early marker. I think that's a major advance.
Was a great summary. And I think so what I take away from this is there were all of these different proposed criteria, and then each institution sort of used their own, and some institutions made up even additional criteria. So Dr. Ho, how do you feel like this impacted the field and so like and are moving forward?
Yes, I think it's great that we now at least have come together and have agreed to a harmonized criteria that both adult and pediatricians can agree to. I really don't think it is two different disease in kids and adults, and therefore having separate criteria for adult and children is really very disruptive and doesn't not promote research. I think having everybody talking the same language and on the same page in terms of making a diagnosis is crucial. Hopefully, this will really facilitate our research going forward.
Yeah, so I think the challenge is if you uh, can't name a disease, how do you develop treatment for it? You don't know what disease you're talking about. How do you even know how much of it you have? And I think
Right.
that has been our biggest problem. And I think hopefully now with having uniform set of criteria, a lot of research will happen and will get more and more information about natural history and predisposing factor and even in adults.
I think you guys are spot on. When we're not even speaking the same language, not even identifying the same patients, it's really challenging. I would say impossible to interpret the data. And so this gap was identified by four major bone marrow transplant societies. So the European BMT, CIBMTR, ASTCT, and the Asian Pacific BMT groups. They all said this is a problem. We need to address it, and got together a group of experts. And we recently published that paper, which has been referenced a few times. So the goal of that group was to try to identify TMA, and we wanted to identify not just the most severe, not just the organ dysfunction, but get criteria that could identify people early. With the really important caveat that we know that when we diagnose earlier, when we have criteria that are somewhat less strict, that you will find more patients. So then risk stratification, figuring out who's going to get sick and who's not, is really, really key. And so we propose that we all use a modified form of the Jodel criteria, which allows for 4 out of 7 features to be present. We want it to be consistent, so show a pattern more than once within a 2-week period, and then consider that those patients are really meeting criteria for TMA. And I think it's really critical that the criteria be applied with the lens of, as Dr. Poppet and Ho have said, many patients post-transplant have anemia. Many patients have thrombocytopenia. So you really sort of have to think and say, is this normal for where they are in transplant? Are there other etiologies? ruling out engraftment failure, ruling out the other things that can present this way. And I think that's how we envision that the criteria be applied moving forward. And so, as Dr. Ho has mentioned, and Dr. Papa, they'd mentioned a lot of things, the blood counts, the destruction of the red cells as evidenced by the LDH or schistocytes, soluble C5b9 as a biomarker. So this is a marker of terminal complement activation, is elevated in some, but not all patients, and is not, none of the markers are specific to TMA alone. But when they happen together, they really do seem to identify, and I think they do work. They do identify these patients. And then the next step is the risk stratification. So Dr. Ho, do you have tips? How do you differentiate? You have this patient who has graft versus host disease and you think maybe has TMA. What are some tips for trying to figure this out?
Yeah, no, it's a challenge. I think, obviously for patients who have intestinal graft versus host disease, and if they start having GI bleeding on top of the diarrhea, uh, a lot of times we will ask our GI colleagues to rebiopsy these patients to look for TA-TMA, because they could now have TMA on top of their GVH and not just progression of their GVH. Because our first inclination is, oh, they're starting to bleed now. Now they have stage 4 GVHD, and you keep piling on immune suppression when without knowing that they actually develop TMA, that they actually need eculizumab rather than than more immune suppression. So that's one, is being vigilant to the fact that TMA can develop on top of GVHD. Uh, in terms of other mimicking diseases, patients with VOD, for example, another endothelial syndrome, they often get renal dysfunction with the VOD, and sometimes they can get TMA complicating the VOD as well. And so the AKI that develops with VOD is usually very much hepatorenal and associated with a lot of fluid avid retention. But if you suddenly see that they have hypertension and now they have new increasing proteinuria with the AKI, then be aware that they could be developing renal TMA in association with SOS of VOD. Um, Similarly, in other organs like in the lungs, patients who suddenly develop increasing pulmonary hypertension, or they start having hemoptysis and then DAH, um, you know, you have to think about the possibility of that they may have pulmonary TMA in that setting as well. And so that's, I think, a bit of an under-recognized condition and certainly now with it's increasingly recognized in our population. These patients with ARDS going to the unit, they have evidence of pulmonary hypertension and no other infectious etiology. Think about the possibility that there's sort of a TMA component underlying this so-called IPS that we see in our transplant patients.
Yeah, so I think that that's very helpful. Uh, in adults, we have been far behind and have not been screening these patients. Michelle, do you screen these patients for this disease?
Yeah, we do. We have implemented routine screening now on our 5th year. So that is blood counts, which I think are standard, LDH, which is standard at some institutions, and then we get urine protein to creatinine ratio on everybody. And we sort of look at the combination of these features. We look for any of the things that Dr. Ho mentioned, very refractory hypertension that is out of proportion. So everybody gets hypertensive on tacrolimus, but most people don't need a drip in the ICU for hypertension. So that gets our attention, those really extreme. So we screen everybody, and if you screen positive, then we do send additional testing for confirmation. So we send soluble C5b9 testing. Again, we're very vigilant looking at echoes for pulmonary hypertension in our sick patients. We do not obtain biopsies routinely unless they're getting intestinal biopsies for graft versus host disease, and then we will always look for TMA there. But we have found that this really helps us, that we're always thinking about it and identifying these patients early. And certainly other institutions do this, and in other retrospective studies, including one led by Dr. Ho and Dr. Poppets at one of the institutions near him in Texas, that they've shown that when you look for the disease, you tend to find it more. And again, not all patients will need to be treated, but some will. And so when you're already sick, when you have diffuse alveolar hemorrhage, that's very difficult to reverse. And so in the paper that we're mentioning, we did propose some features that based on the literature, do predict death, ideally before they get that sick. And so those are the patients that we would propose could really benefit from perhaps a TA-TMA directed therapy. And I know that the adult programs tend, or that many of my adult colleagues tend to not screen as much. Is that accurate for you guys as well?
Yeah, we don't screen as much, and we probably uh, are at the stage where Dr. Ho mentioned that in certain situations, clinical scenarios, we emphasize that our team needs to think about this. But hopefully, we'll move to where you are slowly but steadily now that we have a definition for this disease. Dr. Ho?
Yeah, I agree. I think we're far behind in terms of the screening. We do LDH on all of our patients more very regularly, but we don't do the protein urine protein screening that we probably should be doing.
So in the final few minutes, we talked about identifying the patients, we're stratifying them. Then what do you do with them? So there are two trials. Dr. Ho, can you tell us about one of the trials?
Um, yeah, so there's a in terms of trials that are currently active, there's a phase 3 revolution trial. This is a trial that's going on across the world. And my understanding is that trial is almost near completion of accrual. So we're very excited to look forward to seeing that result. That's a randomized trial that randomizes patients with revolution versus placebo for patients with TMA developing within 1 year of their transplant. And then there is a crossover in that trial for patients who don't respond initially, and if they're unblinded and found to be on placebo, they can be crossed over to receive ravulizumab. Uh, and then there's also a study that was been conducted with naproxen, which is a MASP-2 inhibitor, and that phase 2 study was published a couple of years ago by Dr. Khalid at City of Hope, and the supplement is currently under FDA review, and there's a possibility that it may become FDA approved for the treatment of the HSCT-TMA in this next year.
Michelle, do you want to summarize the eculizumab data in pediatrics?
Sure, yeah. So there's a fair amount of data that's largely single, now multi-institutional, that's retrospective, but there was a paper that was published recently in Blood that described, it was a prospective multi-institutional interventional study, and they gave eculizumab to high-risk pediatric patients. There were 23 that were enrolled, 21 were evaluable for assessment. 5 of those were autologous recipients, so a little bit different perhaps than some of the adult cohorts, but did show very nice survival data, and certainly compared to a historic cohort that seemed to have a survival benefit. And so I think that trial, in addition to the narsoplimab trial that was mentioned, are the two most robust pieces of information that we have at this time that TMA-directed therapy may impact outcomes. Lots of multi-institutional studies, and again, lots of trials coming up, which we think will be really promising, and we're really excited to see those results.
Yeah, I think there are probably around 20 trials going on right now with a number of different compounds, including C5 inhibitors. There are several C3 inhibitors also in trial, at least one C1s inhibitor uh, as well. So that's very exciting, and um, I think this field has really taken off over the last 10 years, and then that's much to the credit of a lot of our pediatricians, and hopefully this will lead to better treatment options for our patients going forward. I think we really do need something that's FDA approved for this condition because sort of obtaining eculizumab approval for use has been somewhat difficult because it is an off-label use.
Yes. So uh, I think we have had this very interesting and worthwhile discussion, and I've learned a lot. Michelle, you want to make any final comments?
No, I echo what you guys have said. I think this is a really exciting time for this field. That there are some unmet needs we all recognize. We wish that we had a single biomarker or biomarker panel that could really confidently identify these patients, and that is something that I know many of us are working towards. So while we wish that were true, in the interim, we do have these criteria that we hope people will use going forward so that we can try to at least, again, all speak the same language, try to understand the real incidence and impact. And again, with all of these exciting studies, we hope that we'll soon have even additional data supporting the use of TA-TMA directed therapies. So I want to thank Dr. Ho and Dr. Poppet so much. Thank you for joining. Thank you for the audience for joining the program. If you could please continue on to answer the questions that follow to earn your CME credit and complete the evaluation. And then another little plug to stay tuned, but we will be having a live social media event, the three of us again to chat more, and we can answer questions during that event. So thank you so much.